Good evening. 7 o'clock. Shall we start or should we wait for some more time?
I think we can start.
Okay. So good evening. Namaskaram. October മാസം നമ്മൾ ബ്രസ്റ്റ് ക്യാൻസർ അവയർനെസ് മന്ത് അഥവാ സ്തനാർബുദ ബോധവൽക്കരണ മാസമായി ആചരിക്കുകയാണ്. സോ ഇതിനോടനുബന്ധിച്ച് ഇന്ത്യൻ റേഡിയോളജിക്കൽ ആൻഡ് ഇമേജിംഗ് അസോസിയേഷൻ പ്രിവെന്റീവ് റേഡിയോളജി IRIA in association with Swasthi Foundation and Association of Malayalam Movie Artists AMMA ഒരു വെബിനാർ സീരീസ് കണ്ടക്ട് ചെയ്യുകയാണ്. ഒക്ടോബർ 1 മുതൽ 30 വരെ രാത്രി 7 മുതൽ 8 മണി വരെയാണ് ഈ വെബിനാർ നടത്തുന്നത്. അപ്പം മെനി എമിനന്റ് ഓങ്കോളജിസ്റ്റ് ആൻഡ് റേഡിയോളജിസ്റ്റ് ടോക്സ് റിഗാർഡിംഗ് ബ്രസ്റ്റ് ക്യാൻസർ അതിന്റെ അവയർനെസ്സും ഒക്കെ ചെയ്യുന്നുണ്ട്. അപ്പം ഈ ഒരു വെബിനാർ സീരീസ് നമ്മൾ നടത്തുന്നത് 2026 ജനുവരിയിൽ നടക്കാനിരിക്കുന്ന ഗ്ലോബൽ പ്രിവെന്റീവ് ഓങ്കോ സമ്മിറ്റിന്റെ കേർട്ടൻ റേസർ പ്രോഗ്രാം ആയിട്ടാണ്. സോ ഈ വെബിനാർ കൊണ്ട് നമ്മൾ ഉദ്ദേശിക്കുന്നത് മെയിൻലി ടു സ്പ്രെഡ് അവയർനെസ് അബൌട്ട് ദിസ് ബ്രസ്റ്റ് ക്യാൻസർ, പിന്നെ അതിന്റെ ഏർലി ഡിറ്റക്ഷൻ, അതിനു വേണ്ടിയിട്ട് നമ്മൾ ചെയ്യേണ്ട കാര്യങ്ങൾ എന്തൊക്കെയാണ്, അതിന് എങ്ങനെ ഫെസിലിറ്റേറ്റ് ചെയ്യാം, അതുപോലെ പ്രിവെന്റീവ് സ്ട്രാറ്റജീസ് അഗൈൻസ്റ്റ് ബ്രസ്റ്റ് ക്യാൻസർ അതിനെ പറ്റിയുള്ള ഒരു അവയർനെസ്സും കൂടെ പൊതുജനങ്ങൾക്കിടയിൽ ഉണ്ടാക്കുവാനായിട്ട് വേണ്ടിയിട്ടാണ്. സോ സ്വസ്തി ഫൗണ്ടേഷനെ കുറിച്ച് പറയുകയാണെങ്കിൽ ഇറ്റ് വാസ് സ്റ്റാർട്ടഡ് ഇൻ 2013 ആസ് എൻ NGO. അപ്പോൾ ഇതിന്റെ മെയിൻ ലീഡർഷിപ്പ് വഹിക്കുന്ന ശ്രീ എബി ജോർജ് സർ ആണ്. അപ്പോൾ ആരംഭം മുതൽ തന്നെ വളരെ സുത്യർഹമായ സേവനമാണ് സ്വസ്തി ഫൗണ്ടേഷൻ ഈ ഒരു ഹെൽത്ത് അവയർനെസ് പ്രോഗ്രാംസ് ഇവിടെ ചെയ്യുന്നത്. മെയിൻലി ക്യാൻസർ സ്ക്രീനിങ് ആക്ടിവിറ്റീസുമായിട്ടാണ് സ്വസ്തി ഫൗണ്ടേഷന്റെ ആ ഒരു മെയിൻ പ്രോഗ്രാംസ് പോകുന്നത്. വളരെയധികം ഹെൽത്ത് റിലേറ്റഡ് ആക്ടിവിറ്റീസ് സ്നേഹതാളം ബ്രസ്റ്റ് ആൻഡ് ഓറൽ ക്യാൻസർ സ്ക്രീനിങ് പ്രോഗ്രാമിന്റെ ഭാഗമായിട്ട് ചെയ്യുന്നുണ്ട്. അതുപോലെ തന്നെ ലൈഫ് സ്റ്റൈൽ ഡിസീസസിന്റെ പറ്റിയുള്ള അവയർനെസ് ക്രിയേറ്റ് ചെയ്യാനായിട്ടുള്ള സ്വസ്തി സൗഖ്യ പ്രോഗ്രാംസ്, ഡിഫറെന്റ്ലി ഏബിൾ ചിൽഡ്രന് വേണ്ടിയിട്ടുള്ള സ്നേഹജ്യോതി, ഐ കെയറിന്റെ ഭാഗമായിട്ട് കാവൽ കണ്ണിന് കാവൽ, അങ്ങനെ നിരവധി പ്രോഗ്രാംസ് ആണ് ഹെൽത്ത് റിലേറ്റഡ് ആയിട്ട് സ്വസ്തി ഫൗണ്ടേഷൻ ചെയ്തുകൊണ്ടിരിക്കുന്നത്. പിന്നെ ഈ ഒരു അവസരത്തിൽ നമുക്ക് പ്രത്യേകം എടുത്തു പറയേണ്ടതാണ് അമ്മ അസോസിയേഷൻ ആയിട്ടുള്ള ആ ഒരു സഹകരണം. കാരണം നമുക്ക് ഈ ഒരു അവയർനെസ് അല്ലെങ്കിൽ ഈ ബ്രസ്റ്റ് ക്യാൻസറിനെ കുറിച്ചിട്ടുള്ള ഒരു അവയർനെസ് പൊതുജനങ്ങളിലോട്ട് എത്തിക്കണമെങ്കിൽ തീർച്ചയായിട്ടും അത് ഒരു മെഡിക്കൽ പ്രൊഫഷണൽസ് അല്ലെങ്കിൽ ഹെൽത്ത് കെയർ പ്രൊഫഷണൽ പറയുന്നതിനേക്കാളും വളരെയധികം റീച്ച് കിട്ടും ഒരു സെലിബ്രിറ്റീസ് വഴി അത് സ്പ്രെഡ് ആകുമ്പോൾ. അപ്പോൾ ഈ ഒരു അവസരത്തിൽ അമ്മ അസോസിയേഷൻ നമുക്ക് നൽകുന്ന സഹകരണത്തിനോട് വി ആർ എക്സ്ട്രീംലി ഗ്രേറ്റ്ഫുൾ ടു ദ അമ്മ അസോസിയേഷൻ ഭാരവാഹികളോടും അതിന്റെ മെമ്പേഴ്സിനോടും. അപ്പോൾ ഇന്നലെ ഒക്ടോബർ 1-ാം തീയതിയാണ് ഈ വെബിനാർ സീരീസിന്റെ ഉദ്ഘാടനം നടന്നത്. നമ്മളെല്ലാം ഇന്നലെ കണ്ടു. ശ്രീമതി മഞ്ജു വാര്യരാണ് അത് നിർവഹിച്ചത്. അപ്പോൾ ഇന്ന് നമ്മൾ 2ാമത്തെ ദിവസത്തിന്റെ കാര്യപരിപാടിയിലേക്ക് കടക്കുകയാണ്. സോ വി ആർ വെരി ഓണേർഡ് ടു ഹാവ് വിത്ത് us as a chief guest Miss Cuckoo Parameswaran. She's a Secretary General of AMMA Association. ഒരു അഭിനേത്രി എന്നതിലുപരി ഒരു വളരെ സോഷ്യലി കമ്മിറ്റഡ് പേഴ്സൺ ആണ് മാഡം. സ്വസ്തി ഫൗണ്ടേഷന്റെ ഒരു ഭാഗമാണ് ശ്രീമതി കുക്കു പരമേശ്വരൻ. നമ്മുടെ എല്ലാ സ്വസ്തി ആക്ടിവിറ്റീസിന്റെയും ഒരു സജീവ സാന്നിധ്യമാണ്. അപ്പൊ മാഡത്തിനെ കുറിച്ച് പറയുകയാണെങ്കിൽ ഷീസ് എ സെൽഫ് മെയ്ഡ് പേഴ്സൺ, ഒരു സ്ട്രോങ് ആക്ടിവിസ്റ്റ് ആണ്, ഒരു സ്ട്രോങ് പേഴ്സണാലിറ്റി ആൻഡ് leadership capabilities നമ്മൾ കണ്ടിട്ടുണ്ട് മാഡത്തിൻ്റെത്. പിന്നെ ഒരു ബഹുമുഖ പ്രതിഭയാണ് ശ്രീമതി കുക്കു പരമേശ്വരൻ. മാഡം ഒരു തിയേറ്റർ ആർട്ടിസ്റ്റ് ആണ്, ഡയറക്ടർ ആണ്, അവാർഡ് വിന്നിംഗ് ആക്ടർ, ഡാൻസർ, ഓണ്ടർപ്രണർ, റിനോൺ ഫാഷൻ ഡിസൈനർ, അങ്ങനെ പല പല മേഖലകളിൽ കഴിവ് തെളിയിച്ചിട്ടുള്ള കുക്കു പരമേശ്വരൻ മാഡം ഇന്ന് ഇവിടെ ചീഫ് ഗസ്റ്റ് ആയിട്ട് നമുക്ക് എത്തിയിരിക്കുന്നത്. സോ വി ആർ എക്സ്ട്രീംലി ഗ്രേറ്റ്ഫുൾ ആൻഡ് താങ്ക്ഫുൾ ടു മാഡം. So we are very proud to have you as a chief guest today. Welcome to this webinar program, madam.
Thank you very much. I think I have to say thanks, because you shouldn't be thanking me, because I'm a part of two organizations which I'm very proud to be. One is AMMA and the second is Swasthi. I'm a trustee of Swasthi as well, and I'm very privileged to be here, and I'm proud to be here. So, and I see it as my duty to be here. As you know, like we say, like you were mentioning, like cinema celebrities, it's not celebrity alone. Cinema is very close to, especially to Keralites, cinema is a part of their life growing up, and film people are already their part of life as well. So when someone from film industry says something, they will take it, listen to it, they'll try to understand, or at least repeat or rethink about it. That is what, it's not just celebrity alone. Cinema is that close to Malayalis. So when Abhichayan, the Swasthi man, I call him, when he mentioned, I said, yes, we will do it. And I have got, being in AMMA, I think this is something we should. And it will benefit us as well as women. At the same time, I see it as a responsibility. You know, being in a position, you have a responsibility towards the society as well. So when I conveyed this to my co-members and my executive committee and my other people, they were saying, let us do it together. So like you said, this is a curtain raiser for a bigger promise, bigger dream, that is the Global Summit, which is going to, Prevention Oncology Summit, which is going to happen in 2026, January 16 to 18. So now coming to breast cancer, you know, we women really need to realize we are important, we matter, and we only matter to us. Enikku njanaan important. There is nothing wrong in thinking that you need to look after yourself. So like airport, nammal flight la irikkumbol parayum, put the mask on you first. So if you love your children, if you love your husband, if you love the world or the job or anything you love, start loving yourself. Adinte ettavum veliya ghadagamana screening, understanding your body, recognize the problem and try to cure it. Itrayum ഒരുപാട് ഡോക്ടേഴ്സും റേഡിയോളജിസ്റ്റും റിസർച്ചേഴ്സും, when they are opening their arms to embrace us and say we are here to help you, I think നമ്മളെ സ്ത്രീകളുടെ ഒരു ഡ്യൂട്ടിയാണ്. When there are people to help you, get up, go to that center and do it. Because നമ്മുടെ ജീവിതം നമ്മൾ തീരുമാനിക്കുന്നിടത്താണ് തുടങ്ങുന്നത്. കാലം മാറി. We are standing in 2025. Health എന്ന് പറയുന്നത് ഒരു ഫാഷൻ അല്ല. Health is must. Health is, let us not make it luxury. Health is something as important as oxygen, as important as water, as important as having a roof on your head, over your head, I mean. So health take care ചെയ്യാൻ സ്ത്രീകൾക്ക്, ഇത് വളരെയധികം കേരളത്തിൽ കണ്ടുവരുന്ന ഒരു ക്യാൻസറാണ് ബ്രസ്റ്റ് ക്യാൻസർ. വളരെ ഈസി ആയിട്ട് കണ്ടെത്താൻ പറ്റും. ഏജ് അനുസരിച്ചിട്ട് ഫിസിക്കൽ എക്സാമിനേഷൻ കൊണ്ട് above 40 we can do scanning and we can do mammogram. ഇതുപോലെയുള്ള ഇതിനെക്കുറിച്ചുള്ള തെറ്റായ ധാരണകളാണ് നമ്മളെ മുമ്പോട്ട് നയിക്കാത്തത്. അപ്പോൾ ധാരണകൾ ശരിയാക്കുമ്പോൾ, ധാരണകൾ തിരുത്തുമ്പോൾ നമ്മളാണ് സ്ട്രോങ് ആവുന്നത്. വി നീഡ് ടു സ്റ്റാൻഡ് ഓൺ അവർ ഫീറ്റ്. അത് മനസ്സിലാക്കി സ്ത്രീകൾ മുന്നോട്ട് വരണമെങ്കിൽ, ഞങ്ങൾക്കത് ഹെൽപ്പ് ചെയ്യാൻ പറ്റുമെങ്കിൽ, let us do it. If we women can help it, we women can do something like that. അതുകൊണ്ടാണ് I really think Amma has to step in and really do whatever we can. So all of us, all the members are ready. to step in, spread the awareness, talk about it, make people understand that breast cancer is something very rapid and it's growing as well. People should check it out and then find, like yesterday, I love the way Manju has said it. It's a win-win situation. When you check it out, and if you find out early, you have something, we can cure it. If you check it out and you find there is nothing wrong, still we are happy. So let us make this a total win in every way. And I wish all the success. I thank Dr. Rijo, I thank Abichai and Swasthi, and I thank all the members who's ready to stand in for it, all the doctors, all the researchers, everyone behind Swasthi. At the same time, all my colleagues and my members for standing with us, understanding the value of the things we are doing and supporting us. So all the best, and let us go ahead for today's thing.
Thank you, madam. So
Thank
thank
you.
you for those motivating words, and from our side, a big congratulations for becoming the first woman General Secretary of AMMA Association.
Thank you.
Thank you, ma'am.
Thank you.
So now we have to welcome two of our eminent doctors for their expert talks. The first talk will be by Dr. Gayathri Gopan. She is a medical oncologist working in GG Hospital and Gokulam Medical College. Welcome, Dr. Gayathri.
Thank you so much. So
Okay, just I'll welcome Dr. Judy also. So second talk will be by Dr. Judy Mary Kurian. She is a State Secretary of Kerala IRIA Association and head of the Department of Radio Diagnosis in Travancore, Medicity, Kollam.
Thank you,
Welcome, Dr. Judy, to this webinar.
Thank you, ma'am.
So we'll go to the first talk. It is by Dr. Gayathri Gopan. She'll be talking on breast cancer risk factors, which every woman should know. Over to Dr. Gayathri.
Thank you so much. Thank you so much, Swasthi, for giving this opportunity to share this very important topic. There are actually so many myths surrounding breast cancer and also cancer as such. Hope my screen is visible. Is my screen visible?
Yes, ma'am.
Yes. So actually, as Cuckoo madam had told, breast cancer is rapidly increasing. Actually, it is the most common cancer worldwide. In India, it is very high. In Kerala, it is very high. It is going on increasing. So we should really know the risk factors regarding breast cancer. And also there are so much information is available online. So we don't know what to trust. Like somebody will be telling taking this food is good, or somebody will be telling doing this thing is good. But so we have to understand, we have to find out the source from which this information is coming before jumping into conclusions. So my topic for today is breast cancer risk factors, what everyone should know. And myself, I am Dr. Gayathri, a medical oncologist working primarily at GG Hospital. And as we all know, October is the Breast Cancer Awareness Month. And let us move ahead with this topic. So breast cancer, as previously mentioned, it is rapidly increasing. The most common cancer worldwide, most common cancer in India, most common cancer in Kerala, and of course the most common cancer in females. And when we see this demographics, this was published in 2020, but of course the numbers will be larger now. The incidence rate in Kerala is much higher than the national average also. We suppose that this is because of the increased detection rate in Kerala, but recently we have concluded that other lifestyle modifications also contribute to this increased incidence of this disease. So there are many myths surrounding this breast cancer. One is important thing is that breast cancer occur only in females. So males think they don't get breast cancer. So breast cancer, the fact should be known by everybody. Everybody should know regarding breast cancer, not only females, everyone should know regarding breast cancer. Breast cancer can occur in males also, but it is very rare. It can occur in males also. It not only occurs in females. And painless lumps can be ignored. Most often people will come to OP. Doctor, കുറേ നാളായിട്ട് മുഴയുണ്ട്, പക്ഷെ മുഴയ്ക്ക് വേദന ഇല്ലാത്തത് കാരണം ഞാൻ വന്നില്ല, അല്ലെങ്കിൽ തട്ടിയപ്പോൾ വന്നൊരു സ്വെല്ലിംഗ് ആണ്, അതിപ്പോൾ ഒരു ക്യാൻസറസ് ആയിട്ട് തോന്നിയില്ല എന്ന് പറഞ്ഞ് ഒരുപാട് ആൾക്കാർ ഒരു അഡ്വാൻസ് സ്റ്റേജിൽ വരുന്നതായിട്ട് നമ്മൾ കാണാറുണ്ട്. And another myth is that mammogram is painful. Mammogram, I agree, is done by compressing the breast tissue, but not always it is painful if we do it in the right manner. And removal of breast is a must for patients with breast cancer. Always people think that if there is breast cancer, you have to remove the entire breast. അങ്ങനെ അല്ലെങ്കിൽ തിരിച്ചു വരാനുള്ള സാധ്യത ഏറുന്നു എന്നുള്ള രീതിയിൽ പറയാറുണ്ട്. പക്ഷെ the thing is that in most of the cases, breast conservation surgery is possible. Rarely we may have to go for total breast removal, but in most of the cases, breast conservation surgery would be enough, and this will be coupled with RP so that the result will be much better. Then people think that only elderly females get breast as well as ovarian cancer. It is not true. We know that young people can also get breast cancer, and sometimes the cancer in young females may be aggressive also. Another myth is that one patient was there, she was 44-year-old lady, she came with a breast lump. അപ്പോൾ പറഞ്ഞത്, ഡോക്ടർ എൻ്റെ വീട്ടിൽ ആർക്കും ബ്രസ്റ്റ് ക്യാൻസർ ഒന്നും ഇല്ല, എൻ്റെ വീട്ടിൽ ആർക്കും ക്യാൻസറേ ഇല്ല, ഇത് പാല് കെട്ടിയതോ ഇൻഫെക്ഷൻ ആണെന്നോ ഞാൻ വിചാരിച്ചു എന്നാണ് ആ പേഷ്യന്റ് പറഞ്ഞിട്ടുണ്ടായിരുന്നത്. So I thought of adding this also to the slide. If there is no family history of cancer, I will not get cancer. It is not like that, because it is not always genetic or familial. There are other causes for breast cancer, and that person may be the index case. ആ കേസിൽ നിന്നായിരിക്കും മറ്റ് ക്യാൻസർ കേസസ് തുടങ്ങുന്നുണ്ടാവുക. And cancer cannot be prevented. It is not true. Cancer can be prevented, and many cancers can be prevented. So we will come to the risk factors associated with cancer. Before that, everybody asked, പണ്ട് ഡോക്ടർ ഇത്രയും ക്യാൻസർ ഉണ്ടായിരുന്നില്ലല്ലോ, ഇപ്പൊ ഇത്രയും ക്യാൻസർ കൂടാനുള്ള കാരണം എന്താണെന്നാണ് നമ്മൾ ഏത് അവയർനെസ് സെഷനിൽ പോയാലും ചോദിക്കുന്ന ആദ്യത്തെ ചോദ്യം. So definitely cancer is on the rise. One important thing is the lifestyle changes. Definitely the lifestyle changes. The increasing lifespan. പണ്ട് ആൾക്കാർ ഇത്രയും നാളല്ല ജീവിച്ചുകൊണ്ടിരുന്നത് അല്ലേ. ഇപ്പം എന്ന് പറഞ്ഞാൽ 60 years is not at all an old age. So increasing lifespan, because increasing age itself is a risk factor for cancer, not only breast cancer, other cancers also. So increasing lifespan itself leads to increase in breast cancer, and we have more access to information. People ഇപ്പോഴും പല ആൾക്കാരും ഈ പറഞ്ഞ ലേറ്റായി നമുക്ക് ഡയഗ്നോസിസ് വരുന്ന ഒത്തിരി അധികം ആൾക്കാരുണ്ട്. എന്നിരുന്നാലും പല ആൾക്കാരും എനിക്ക് സ്ക്രീനിങ് ചെയ്യണം എന്ന് പറഞ്ഞു വരുന്ന ആൾക്കാരുണ്ട്. അങ്ങനെ വരുമ്പോൾ ഡെഫിനറ്റ്ലി ക്യാൻസർ ക്യാൻ ബി ഡിറ്റക്റ്റഡ് early, and that will also result in a rise in the statistics. So all these contribute to increase in cancer numbers. So now let us move on to the topic proper, that is the risk factors associated with breast cancer. So one thing I would like to say is that it is multifactorial. In most of the cases, you will not be able to pinpoint this as the cause for cancer. So mostly it is multifactorial. So what are the main causes? We know that most of the causes for cancer are modifiable. That is something which we can do about. That is mainly associated with the lifestyle. 90 to 95% it is something which we can do about. Then we have non-modifiable factors, that is genetic and also age-related, sex-related. As we previously mentioned, female sex is associated with increased incidence of cancer. But males can also get cancer. We know that female hormones play a very important role in the development of breast cancer. So this is a factor which we cannot do anything about. Increasing age is a factor we cannot do anything about. Genetic factors also we cannot do much about. So these are the non-modifiable factors, but definitely there are certain modifiable factors which we have to emphasize and do preventive measures. So the main causes of breast cancer, as we can see here, one is the female sex itself, as we mentioned, but males can also get breast cancer. Older age, as age increases, there is increased chance of developing breast cancer. Then racial and also ethnic differences are also there in this breast cancer. Mainly black people can develop breast cancer. Then family history of breast cancer. We will come to that in detail. It is so ഈ ഫാമിലി ഹിസ്റ്ററി എന്ന് പറയുമ്പോൾ പല ആൾക്കാർക്കും പേടിയാണ്. അതായത് ഈ നമ്മൾ പറയുന്നത് അടുത്ത ഫാമിലി മെമ്പേഴ്സിന് ബ്രസ്റ്റ് ക്യാൻസർ ഉണ്ടെങ്കിലാണ് ഒരു പേഴ്സണിന് കൂടുതൽ ചാൻസ് ബ്രസ്റ്റ് ക്യാൻസർ വരാനായിട്ട്. അടുത്ത ഫാമിലി മെമ്പേഴ്സ് എന്ന് പറയുമ്പോൾ ഫസ്റ്റ് ജനറേഷൻ അല്ലെങ്കിൽ സെക്കൻഡ് ജനറേഷൻ, അച്ഛൻ, അമ്മ, മക്കൾ ഒരു ഫസ്റ്റ് ജനറേഷനിലാണ് വരുന്നത്. പിന്നെ ഗ്രാൻഡ് പേരൻസ്, ഗ്രാൻഡ് ചിൽഡ്രൻ, അങ്കിൾ അങ്ങനെയൊക്കെ പറയുമ്പോഴാണ് സെക്കൻഡ് ജനറേഷൻ വരുന്നത്. ഡിസ്റ്റന്റ് റിലേറ്റീവ്സ് ഒക്കെ ബാക്കിയുള്ള എല്ലാവരെയും നമ്മൾ ഡിസ്റ്റന്റ് റിലേറ്റീവ്സ് എന്നാണ് കൺസിഡർ ചെയ്യുന്നത്. അങ്ങനെ ഒരുപാട് ഡിസ്റ്റന്റ് റിലേറ്റീവ്സിന് എന്തെങ്കിലും ക്യാൻസർ ഉണ്ട് എന്നുണ്ടെങ്കിൽ നമുക്ക് ക്യാൻസർ വരാനുള്ള സാധ്യത അധികം ഇല്ല. എന്നിരുന്നാലും ഫാമിലി ഹിസ്റ്ററി ടേക്കിംഗ് ഇസ് വെരി ഇമ്പോർട്ടൻറ്റ്. ദാറ്റ് ഇസ് who was diagnosed with cancer, at what age cancer was diagnosed, what type of cancer did the patient have, what type of treatment did the patient take. All these things are very important in family history taking of any cancer. Then breast density, we'll come to that. Benign breast diseases, previous history of breast cancer, then age at menarche as well as menopause. അതായത് നേരത്തെ ഉണ്ടാവുന്ന ആർത്തവാരംഭം, വൈകി ഉണ്ടാവുന്ന ആർത്തവ വിരാമം, ഇതെല്ലാം തന്നെ these are risk factors for breast cancer. Then using OCPs, is it harmful? Diet, nutrition, alcohol consumption definitely is a risk factor for any malignancy. Overweight and obesity, that is post-menopausal females, periods കഴിഞ്ഞിട്ടുള്ള ആൾക്കാരാണെന്നുണ്ടെങ്കിൽ obesity has an increased risk factor. It is an increased risk factor for the development of breast cancer. Physical activity always protects against cancer, and reproductive history, all these things are very important in the development of breast cancer. So this is our very well-known cancer textbook. This table is actually from our most authentic cancer textbook, and this shows that in the risk factors we previously mentioned, the highest risk is for this genetic factor, that is BRCA1 and 2. നമുക്ക് ആഞ്ചലിന ജോളിയുടെ കാര്യം നമുക്കറിയാം. ആഞ്ചലിന ജോളിക്ക് മ്യൂട്ടേറ്റഡ് ആയിട്ടുള്ള BRCA1 അല്ലെങ്കിൽ BRCA ജീൻസ് ആണ് ഉണ്ടായിരുന്നത്. അതായത് അവർക്ക് ക്യാൻസർ ഇല്ലെങ്കിൽ പോലും അവരുടെ ബോഡിയിൽ മ്യൂട്ടേറ്റഡ് ആയിട്ടുള്ള ഇത്തരം ജീൻസ് ഉണ്ടായിരുന്നു. ദാറ്റ് ഇസ് എവറി പേഴ്സൺ ഹാസ് ദിസ് BRCA. When this BRCA is mutated, that person has an increased risk of developing breast cancer or ovarian cancer or other cancers. So, ഇതിൽ mutation വന്നു കഴിഞ്ഞാൽ there is a chance of developing breast cancer, and the relative risk when compared to the general population is high. When there is a benign breast disease like atypical hyperplasia, നമുക്കറിയാം എല്ലാ ബ്രസ്റ്റിലെ തടിപ്പും ക്യാൻസർ അല്ല. ചില തടിപ്പുകൾ ഒരു കുഴപ്പവും ഇല്ലാത്ത തടിപ്പായിരിക്കാം, പക്ഷെ ചില തടിപ്പുകൾ നമ്മൾ ശ്രദ്ധിക്കേണ്ട തടിപ്പുകളായിരിക്കാം. അതിലുള്ള ഒന്നാണ് എറ്റിപ്പിക്കൽ ഹൈപ്പർപ്ലേസിയ എന്ന് പറയുന്നത്. നമുക്ക് ബയോപ്സി വഴിയാണ് നമുക്കിത് മനസ്സിലാവുന്നത്. എറ്റിപ്പിക്കൽ ഹൈപ്പർപ്ലേസിയ ഹാസ് ഗോട്ട് എ ഹയർ റിസ്ക് ഓഫ് ഡെവലപ്പിംഗ് ബ്രസ്റ്റ് ക്യാൻസർ. ദെൻ റേഡിയേഷൻ എക്സ്പോഷർ ബിഫോർ 30 years. അതായത് ഇപ്പൊ നമ്മളിപ്പോ വേറെ എന്തെങ്കിലും ക്യാൻസർ, ഇപ്പൊ ലിംഫോമ അല്ലെങ്കിൽ ഇപ്പം ബ്ലഡ് ക്യാൻസർ അങ്ങനെയുള്ള എന്തെങ്കിലും ഒരു അവസ്ഥയിൽ നമുക്ക് റേഡിയേഷൻ എടുക്കേണ്ടി വന്നിട്ടുണ്ടെന്നുണ്ടെങ്കിൽ again there is a increased risk of developing breast cancer. So this is having a relative risk of more than 4. Then relative risk 2 to 4, അതായത് കുറച്ചും കൂടെ റിസ്ക് കുറഞ്ഞതാണ് ഈ ഫാമിലി ഹിസ്റ്ററി. ഫസ്റ്റ് ഡിഗ്രി റിലേറ്റഡ് വിത്ത് ബ്രസ്റ്റ് ക്യാൻസർ, certain mutations. Then remember, ഇതാണ് റീപ്രൊഡക്റ്റീവ് ഹിസ്റ്ററിയുടെ ഇമ്പോർട്ടൻസ്. ഇപ്പൊ നമ്മൾ എല്ലാ കുട്ടികളും നമ്മൾ വൈകി ജനിക്കുന്ന ഒരു കാലഘട്ടമാണ്. അപ്പൊ ഏജ് മോർ ദാൻ 35 years is a proven risk for breast cancer. 35 years for first birth is a risk for breast cancer. Then proliferative breast disease, we'll come to that. And mammographic breast density. Mammographic breast density എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ നമ്മുടെ ബ്രസ്റ്റിൽ നമുക്കറിയാം ഗ്ലാൻഡുലാർ ടിഷ്യൂ ഉണ്ട്, അതല്ലാതെ ഫാറ്റ് പാരങ്കൈമൽ ടിഷ്യൂസ് ഉണ്ട്. ഗ്ലാൻഡുലാർ ടിഷ്യൂ അധികമായിട്ടുണ്ടെങ്കിൽ ബ്രസ്റ്റ് ഡെൻസിറ്റി അധികമാണെന്നാണ് പറയുന്നത്. So if there is increased breast density, there is a small increased risk of developing breast cancer. മറ്റ് ഹോർമോണൽ ഫാക്ടേഴ്സ് നേരത്തെ പറഞ്ഞതുപോലെ ഏർലി മെനാർക്കി, ലേറ്റ് മെനോപോസ്, നള്ളിപ്പാരിറ്റി കുട്ടികളില്ലാത്ത അവസ്ഥ, ഈസ്ട്രജൻ ആൻഡ് ഓൾസോ പ്രൊജസ്ട്രോൺ, ഹോർമോൺ റീപ്ലേസ്മെന്റ് തെറാപ്പി, ആൽക്കഹോൾ യൂസ്, പോസ്റ്റ് മെനോപോസൽ ഒബീസിറ്റി, ആർത്തവ വിരാമത്തിന് ശേഷം ഉണ്ടാകുന്ന ഈ നമ്മുടെ ഒബീസിറ്റി എന്ന് പറയുന്നത് എല്ലാം തന്നെ risk factors for breast cancer. So again, according to the relative risk also, we have classified the risk factors for the development of breast cancer. So first I will talk about weight and also body fat in postmenopausal females. Actually postmenopausal എന്ന് പറയാൻ കാരണം in premenopausal ആണെന്നുണ്ടെങ്കിൽ actually the data is not very conclusive. So in postmenopausal females നമുക്ക് ഈ ഫാറ്റ് കൂടുന്ന സമയത്ത് ആ ഫാറ്റിൽ ഉണ്ടാകുന്ന ഈ ഈസ്ട്രജൻ പ്രിക്കേഴ്സേഴ്സ് ഈസ്ട്രജനായി മാറുകയും അങ്ങനെ ബ്രസ്റ്റ് ക്യാൻസർ കൂടാനുള്ള സാധ്യതയുമുണ്ട്. There is an increased chance of development of breast cancer. Hyperinsulinemia can also result in the development of breast cancer. So this is the fact in postmenopausal females. So when there is obesity, there is an increased chance in postmenopausal females for the development of cancer. So this is where physical activity plays a very predominant role. Then,
excuse me, Gayathri.
yes, sir.
There is a request that you should speak in English because most of the listeners
Okay,
don't understand Malayalam.
Okay, sir. Okay. So weight and also body fat in postmenopausal females. So I'll talk from this, no sir, or should I go to the previous slides?
No, you can continue from here, but
Okay. Yeah, fine.
Yeah.
So in postmenopausal females, actually increase in the fat will result in more estrogen. So this more estrogen can result in increased chance of development of breast cancer. So that is the relationship in postmenopausal females with obesity. But in premenopausal females, the data is not that conclusive. Now, another thing that the patients ask is regarding OCP use, oral contraceptive pill use. Is there increased risk for development of cancer? So this is a very controversial area. There are actually different thoughts, there are different opinions, there are different conclusions in different studies. But the conclusion, actually after studying there is different reports, the conclusion is that there is little to no increased risk of breast cancer based on observational data. Even if there is an increase, that increase is limited to current or recent use, that is within 5 or 7 years use. That is, this risk is limited to this much years. It is not not a permanent thing. Even if you use OCP, there is increased risk of breast cancer. We cannot talk like that. But for patients with a personal history of breast cancer, using OCPs, it is not recommended. Even if contraception is required, we advise regarding barrier contraception and not using OCPs. But females having hereditary predisposition to the development of breast cancer, such as a BRCA gene or a family history of breast cancer, may safely use oral contraceptive pills. So this is not hardcore evidence based. These are all based on observational data. So there is little or no increased risk of breast cancer based on observational data. Now, another very important thing that we have to understand is that all lumps in the breast are not cancerous. There are benign breast diseases also. So one very common breast disease that we see, most people panic and come to the OP and they say that, doctor, the mammogram is showing the presence of cyst. Is it something to worry about? So people ask like that. So we can classify the benign, that is non-cancerous breast diseases, into mainly 3. That is a non-proliferative disease, proliferative disease without atypia, and proliferative disease with atypia. What we have to understand is that non-proliferative disease such as breast cyst, galactoseals, which may be seen in lactating females, then mild hyperplasia, epithelial related certain calcifications, there is no increased risk. There is no increase. So we needn't worry about all the breast lesions. We need not worry. But definitely we have to see an oncologist to understand whether there is a risk of development of malignancy in the future. If it is a proliferative disease without atypia is another thing. In this, there are different conditions are there. There is a small increased risk when compared to the general population for the development of breast cancer. That is the reason why I told that you have to check with the oncologist regarding all these different things. But there are certain diseases which require caution. That is atypical ductal hyperplasia, lobular hyperplasia, and also LCIS. This has got a high risk, and sometimes we may have to give some preventive measures to decrease the future risk of developing breast cancer. So all benign breast diseases are not cancerous. So always people will come and ask, they may be having some mobile lump that freely moves in the breast. That may be a fibroadenoma. Doctor, do I need to remove the fibroadenoma? So fibroadenoma is not cancer. It is a benign breast condition. But there are different types of fibroadenomas are there. Simple fibroadenomas are there. There is no need to remove the fibroadenoma. There is no chance for it to become malignant. But there are certain other types which are rare. There are certain other types, but in those types, caution has to be there and regular follow-up is necessary. Now, another is what we mentioned previously, dense breast. So, I actually mentioned what is dense breast. That is a relative amount of glandular and connective tissue to the adipose tissue. So, dense tissue comprising more than 75% of the breast. Some increase in cancer incidence has been found in such females. The relative risk is 2 to 4. Now we have heard a lot about Angelina Jolie and also other persons regarding the genetic causes. Mainly it is about 10%, and mostly it is the BRCA1 and also genes. These are the main genes involved in genetic susceptibility. This is associated with early onset breast cancer. So when we see breast cancer in females at a younger age, so maybe less than 60 years, in certain types of breast cancer like triple negative breast cancer, when there is bilateral cancers, or in this multiple breast primaries if it is present, or in patients with male breast cancer, or if that person herself had a history of either ovarian cancer or pancreatic cancer. In such situations, we think about genetic causes and we give genetic counseling and we test for such mutations. And if such mutations are present, we ask for their family members also to get tested for these mutations so that preventive steps can be taken. So there is an increased lifetime risk for the development of breast cancer or other malignancies for patients with or persons with such genetic causes. So this is what I mentioned. We'll suspect genetic causes if they are diagnosed early in certain histologies like triple negative histologies. And definitely we do the genetic testing if it has some treatment implication. Like in some cases, we will be able to target the genetic mutation and we will be able to give certain drugs, for example, PARP inhibitors. In such situations, we do genetic testing. So, is somebody talking to me? Okay, so what I wanted to conclude is that the cause is multifactorial. In most cases, we may not be able to pinpoint. Regular physical activities and also lifestyle modifications will help. All breast lumps are not cancerous, but regular checkup is necessary to understand if it is benign or whether if there is any future risk of development of malignancy. There are different hormonal, lifestyle as well as genetic causes for this breast cancer. So thank you so much.
Thank you, Dr. Gayathri. It was a very informative and excellent talk. So one doubt I wanted to ask, how frequently do you recommend mammography and also any blood test, like any tumor markers would you recommend for screening, especially in high-risk category patients?
Yeah. So mammogram, there are different recommendations are there. So after 40 years, yearly mammogram is the one that is recommended. Certain European guidelines recommend after 50 years, 2 yearly mammogram is recommended. So if there is any history of cancer in the family, it is better to do after 40 years, yearly mammogram. Okay. There are no tumor markers as such as of now for detecting breast cancer early.
Okay, thank you.
So we have to do a mammogram itself.
Okay, thank you, Doctor. And one comment has come from Mrs. Kartiyani that one lady whom I know had a mammogram done but after 1 month, a malignant tumor was found in her breast. So we are dealing with sensitivity. How sensitive or specific is this mammogram?
This sometimes happens. This usually happens in the case of aggressive tumors. Aggressive tumors. In between interval breast cancers can develop. There is actually an entity itself. Between the two mammograms, sometimes aggressive tumors can develop, but it is very rare. It is very rare, but this can happen sometimes. Mammogram is sensitive. Mammogram is sensitive, and there isn't much of radiation involved in mammogram. It is equivalent to that of a chest X-ray only. So mammogram taking is always better, but sometimes aggressive tumors can happen in between.
Okay, thank you, Dr. Gayathri. Do we have any other comments or doubts from our guests? Dr. Ansar.
That is a excellent talk from Gayathri. And regarding mammogram, this interval lesions, sometimes in large breasts, when we take mammogram, some area can be missed, and for which we have to take special views. That is one situation where a lump can be missed in a mammogram, and immediately, within 1 month, a patient can present with a lump or a malignancy. But as Gayathri said, it's a very, very rare situation, and we should not take that into account for doing screening mammograms.
Thank you, Dr. Ansar. So I think we'll go on to the second talk. A talk is by Dr. Judy Mary Kurian. She'll be talking on the difference between screening and diagnosis. So over to Dr. Judy.
Thank you, ma'am. First of all, let me thank President of AMMA Association, Mrs. Shweta Menon, ma'am, Secretary General, Mrs. Cuckoo Parameswaran, ma'am, Vice Chancellor, Professor Dr. Mohan sir, with Swasthi Foundation Chairman, Dr. Chandra Mohan sir, and all the members of the foundation, along with the Kerala IRA President, who is with the Swasthi Foundation member, Dr. Rijo Matthew sir, and of course, IRA Kerala, who are major factor behind us for this wonderful association in this campaign. Let me share my screen. Okay. I hope my screen is visible right now.
Yes.
Okay, now first, I've been given the topic, difference between screening and diagnostic mammo. Screening, the purpose why we do a screening test or a screening mammogram, X-ray mammogram, that is basically here we have a clear detection of any potential CA in an asymptomatic patients before they become actually palpable. So whether they are above the age of 40 or less than 40, of course, they go ahead with a breast clinical examination, but most of them do not turn up, but because they are asymptomatic. But if they go ahead for a screening X-ray mammo after the age of 40, definitely we tend to detect. And this is just to detect a early breast CA. So one method being the clinical breast examination, and the next, which of course, where they are referred to us for an X-ray mammo or an ultrasound or an MRI. So basically, it is to identify individuals who may require further evaluation. So how is it different from a diagnostic test or a diagnostic mammogram? Here, the purpose is to confirm a presence of a breast lesion, or to determine the type, or to do the staging, or of course the extent to neighboring tissue. So here again, we have the same set of tests, that is the mammogram or the ultrasound or the MRI. And along with that, of course, we go ahead with a tissue biopsy and conclude with a histopathology diagnosis. So here we have a nearly a definite diagnosis, and helps in treatment guiding the oncologist for further treatment. So I just put this slide on just to tell you the different types of symptoms the patient can come. Of course, most of our patients may be asymptomatic when we do X-ray mammo, but or if not, if they come with symptoms, they may come with a nipple discharge, or it can be bloody discharge, or nipple changes that can be either retracted nipple, or they can come with a lump, of course, but maybe it will be during the later stage. But they can present with a lump, or if not, any changes in the breast color, or some kind of pitting of the breast skin, or if not, just with the pain. So the key difference, screening test, like I said earlier, they are usually asymptomatic individuals. Okay, they just come just because they are at the age of 40 or above the age of 40, and they perform a scan and incidentally detect a lesion. And here it's usually it's a less invasive and less detailed study. Okay. And when it comes to a diagnostic imaging, here they come with a particular symptom, and they have an abnormal screening results, and then they come for further tests. And of course, this aims to see whether there's a presence or the absence of malignant lesions. So understanding the difference, screening, imaging, or test usually involves a routine symptom-free testing, that is asymptomatic individuals. And then this is only to detect the breast cancer early. Whereas a diagnostic test or a diagnostic mammogram, it is more of a detailed and in-depth investigation. And this is to confirm whether there is a malignant lesion. And of course, unless the screening may be showing, of course, they have undergone a screening, and they incidentally detect a lesion, and then they have come for a detailed view or a more detailed views. So coming to screening mammo, of course, usually it's done at the age of 40, but of course we do it a bit earlier also. That is in women who have maybe a family history of CA, or some kind of strong predilection for developing malignancy, or if not, they have they undergo a risk assessment tool, which based on their family history, or if not, they have undergone some genetic testing, which they have a breast BRCA or a BRCA2 gene mutation, or if not, they have a family sibling or child who have this kind of a gene mutation. Or if not, they have had radiation treatment over the chest, which is closer to the breast, before the age of 30. Or if not, they have some syndromes which have a strong predilection to have breast malignancies. Then I've just put this slide, risk of breast CA by age. That is at the age of 30, it can be like 1 in 204. This is actually based on the census taken at the US. So age group of 40, that is 1 in 65, can be found malignant. Age of 50, 1 in 42, age of 60, 1 in 28, and age of 70, 1 in 24. The more the age progresses, of course, the chances of having a breast lesion is higher. So I've put up a slide just to show different types of breast parenchyma, that is more of a fatty breast parenchyma, or if not with fibroglandular density, or it could be heterogeneously dense or kind of extremely dense. So these kind of breasts, actually the ones which are extremely dense, there are more chances of us, or if not, masses being obscured because of the density. And that is one of the reasons that we try to avoid as much as possible to have younger individuals going through a X-ray mammogram, considering that their breast tissue is usually dense. So as the age progresses, we are hoping that the breast tissue is more fatty rather. So coming to screening mammogram, so some of the features that we look into is one, the breast density. So like I said earlier, the breast tends to be denser when they are younger, thereby that is one of the reasons that we try to avoid. But of course, we have ultrasound mammo where we do using ultrasounds. But of course, we do X-ray mammos to look for calcifications. But again, this is one of the reasons. To complicate matters, it's more difficult for the radiologist to look for lesions on a mammogram if the breasts are dense. So, of course, you can discuss with the doctor to go ahead with an ultrasound or further testing like an MRI. Then, what are the other things that we look into is one, calcifications. We have got different types of calcifications. They can be macro calcifications or a larger kind of calcifications or micro calcifications. But of course, both can be seen like as in macro, okay, to a certain limit, like they are more benign. But whereas, and they can be seen, of course, in inflammation, infection, or any history of trauma. Then coming to microcalcifications, they can also be benign, but they have more chances of course, proving that they are malignant, especially when they are more what you call focused, or if not focal or like kind of segmental and so on. Then screening mammo, then coming to masses. So masses is like an abnormal breast tissue that can have either edged edges or what you call or a kind of spiculated margins. So they are like solid lesions. Of course, I've kept another what you call image over here to show how, I'm not able to see from here, but then to show how well demarcated a benign lesion may look. So that could be either a cyst or a fibroadenoma and so on. So this is how a malignant lesion could look on an X-ray mammogram with spiculated margins. Then, of course, asymmetries. Of course, we could have what you call different like an asymmetric tissue. It could be, of course, probably because of a scar or previous trauma history or surgical history. So we could at least ask for a prior history while we are interpreting these images. Then coming to recommendations, which was asked earlier, of course, or if not the doctors or oncologists, or if not gynecologists or whoever the referral consultants are, they of course ask for an annual, or it could be even biannually depending on the age group, or if there's a strong history, family history of breast CA, or if not a genetic predisposition. Then coming to diagnostic mammo. So which all do we ask for a diagnostic mammo? Of course, when, as mentioned earlier, if they come present with a lump or a mass or basically a swelling, or if not either a regional or a focal area of swelling, or if not the entire breast is like quite swollen, or if not skin dimpling like seen like this, or if not you see a nipple that is being retracted or towards inwards kind of, or if they come with a nipple discharge, that is it needn't be clear fluid or milk, but can be even blood tinged, or if not they come with a lump at the level of the axillary region. Then coming to differences in the mammogram, that is screening versus diagnostic. So in both cases, of course, the procedure is really the same, more or less the same. So we subject the patient to the same machine where the patient, what we introduced or help they introduce the breasts into those, they are compressed using those clear plastic paddles, and before these images are being taken. And of course, we tell them do not use lotion or perfume. Then we ask for history like implants, breast implants, and so on. So what is the actual difference between the screening versus the diagnostic mammo? Screening, basically, we use only two kind of images, that is medial, lateral, oblique, and the craniocaudal views. It can be, of course, right and left breast. So totally acquiring those 4 images on a film. Or when it comes to diagnostic mammograms, they are more what you call detailed views that could be like these, like spot compression views. That is, if you see a lesion, or if you have a what you call unsure that there is a lesion, of course you take dedicated views or detailed views. So that is spot compression magnification view, or a cleavage view, or an axillary tail view, such as this. Of course, these are like if there's a lesion towards the periphery or towards the axillary region, and of course you acquire them. Then regarding the dose, of course, this is X-ray, and X-ray, the safer ones are ultrasound and MRI. But of course, X-rays, the reason why we take screening mammo, of course, to look for calcifications. And And of course, the more number of images that have been we capture, we end up exposing to radiation. But of course, the doses are still really small, and the benefits of mammograms outweigh the negative effects of radiation exposure. So if there's any discomfort or something, feel free to ask, or at least speak to us that you don't wish to go further for repeated imagings, or if not, you speak with the referring consultant that, okay, this is enough and I stop there, or if not, or you may even ask for if there are any other further tests that I could do without radiation. So again, I just put the slide for screening mammogram versus diagnostic. These screening mammo is basically for asymptomatic women. This is to detect breast sear early. And diagnostic mammo, of course, if screening mammo turns out to be positive, you go for a detailed view. Then coming to indications, those who are above 40 years of age, and of course, unless if they are having strong family history, definitely we go for lesser age group. And techniques, just those two, mainly the two views of the four views of the breast, that is the medial lateral oblique and the craniocaudal view. And whereas in the diagnostic one, we have spot compression, magnification view, and the cleavage view, and axillary view, and tail view, and so on. Regarding the interpretation, it's almost the same. And of course, they'll guide you for further testing if needed, or assessment or if needed, or to get back after 3 months, 6 months, and so on. That depends on the findings that we come across. And same goes with the follow-up, or if not, we ask for a repeat scan and so on. It needn't be X-ray, but of course, an ultrasound or a mammogram or an MRI mammogram. Then regarding a few pitfalls that we come across, one, if the breast is not adequately compressed, so this is the limited breast tissue view that we could receive, versus if it is completely done at the right way, you could get the entire breast and of course examine go through the image rightly. Thereby lesser chances of missing a lesion if it is a periphery located lesion. Then coming to the nipple, that could also mimic as a lesion. So of course, if done accurately, if the technique is done accurately while acquiring, while placing the breast and having the nipple, unless it's a retracted nipple and so on. Then coming to artifact or a body part that is overlapping the breast, it's always better to place the patient properly and of course acquire the images. Then coming to limitations, screening tests, they are not perfect. Of course, they have limitations like false positives and false negatives. False positives like detecting a mass-like lesion. We have got, it could be an inflammatory lesion, and that could mimic malignancy, or if not, it's false negatives like missing a malignant lesion because of a dense breast parenchyma, or because of these artifacts or the limited way of doing it. Depends on the way the patient must have stood, or maybe they are not able to take the pain or so on. So it's always up to us or our technician who is performing the test, like to detail the patient first on how the test is being done, so that they are also kind of ready, and then convey it. Okay, this is how the test is going to be done, and then acquire the images rightly. Then occurrence of overdiagnosis, detecting cancer it can be never okay. Then of course, if they have a breast implant, this is always better that it is mentioned, and we could go for further testing so that to avoid any artifacts. Then the take-home points. One, of course, a patient more than 40 years of age must go through a screening mammo, unless they are less than 40 and have a strong family history, or maybe syndromes, or a breast BRCA gene mutation, BRCA1 or 2 gene mutation, or family history, of course. And the risk is not in not screening. That means the treatment advances are important, but can overcome the disadvantages of being diagnosed with an advanced stage later. Conclusion, understanding the difference between screening and diagnosis is often effective for breast cancer management, and we need regular screening, of course, and prompt medical attention. Of course, do not forget to take a screening mammogram if 40 years of age or later, or if not, if less than that, of course, if you have a strong family history, do not hesitate. And with this, I think I would like to thank the AMMA Association along with Swasthi Foundation, as well as all our IRIA team for this campaign and mission, and for the upcoming Preventive Onco Summit. Wishing everybody all success. Thank you.
Thank you, Dr. Judy. It was an excellent talk, very informative and elaborate. Thank you. So one question I wanted to ask you, when post breast cancer treated patient, when they come for follow-up, what is the imaging modality that you would prefer? Like, is it a mammogram or you would prefer ultrasound or an MRI?
Ma'am, we go through all, we receive patients for all, whether it is X-ray mammo or whether, and of course, when they come for X-ray mammo, we end up doing concomitantly, we do an ultrasound as well. So that whatever lesions that we see on ultrasound, on X-ray, so that we tend to not miss it on ultrasound, or if not, we can correlate with an ultrasound findings, or if not, for the lesion, the position or the extent and so on. And there's a lot of points that we get on ultrasound, no doubt, whether it is just skin thickening or maybe there's no lesion per se, but we'll have a rough idea on how things are. And regarding MRI mammo, it's a little bit expensive. Not to forget, they have gone through the whole trauma again, and subjecting them, I do not know. I feel we are welcome to all three modalities, no doubt.
Okay. Thank you, Dr. Judy. Do we have any other comments from anyone? Dr. Riju Matthew, would you like to comment?
Thank you, Judy. It was an excellent presentation, and the role of screening mammography is still very low in our state and even in our country. So it's high time that message has to go through, and especially ladies above the age of 40 should definitely undergo a screening mammogram. And like in US, what they did after 1970, which became very effective in detecting early cancers, and the survivors' quality of life also readily improved. So it is time for India also, with the kind of incidence of breast cancer rising, and especially in Kerala, this kind of a mandatory screening voluntarily, or programs like this, campaigns like this, should motivate every individual, every female above the age of 40 to undergo a screening procedure. And that message has been well communicated with both the talks. And thank you very much, Dr. Gayathri, Gopan, and Dr. Judy, for the wonderful presentation.
Anybody else would like to comment? Okay, so thank you very much, Dr. Gayathri and Dr. Judy. Both of you gave a very excellent talks on your topic. It was very informative for doctors as well as for the general public, and also big thanks to Srimati Cuckoo Parameswaran, who gave a very motivating talk. And I thank all members of Swasthi Foundation, AMMA Association, and Indian Radiology and Imaging Association members who for their collaboration in making this webinar series a big success. So we are looking forward to the coming days where we will have more Star Wars talking on very important topics. So thank you very much. So good evening. So I think we'll wind up today's session. Thank you so much.
Thank you, Dr. Kavita Devin, for wonderfully moderating the session.